Hi everyone, welcome to researchmd.com. Great presentation today. We're going to teach you everything about second degree heart block, MOBITZ type 1. That's our presentation today. And my name is Pramil, Cheriyath, Program Director, Internal Medicine Residency, Transitional Residency. I teach medical students and residents on a regular basis. I'm also Director of Research and Assistant Medicine, two major medical schools, okay? So when you talk about AV block or atrioventricular block, it's an interruption or delayed conduction between atria and ventricles. I think everybody pretty much know that, right? There are 3 degrees of AV block actually. And then you got what is like, today our topic is like MOBITZ type 1. It's a type of second degree AV block which is called actually Wenckembach block, okay? It's a benign irregular cardiac rhythm that generally reflects a block in the AV node and the prognosis is pretty good. So in MOBITZ type 1 there is increased PR interval, irregular PR interval, and the AV conduction ratio is like around 4:3. Now, what are the causes or etiology? There could be like structural causes, many neurocardiogenic causes, and toxic metabolic causes. So that's very important to rule out all the reversible causes. Okay, when you look about the structural heart disease, like ischemic heart disease, definitely you have to rule out an MI, chronic ischemic cardiomyopathy, congenital heart disease, post-cardiac intervention, like especially after CABG, those kind of things. And then you have neurocardiogenic, increased vagal tone, healthy individuals with a high level of when they do like exercise, and obstructive sleep apnea, vomiting, and all of those kind of things. And then when you talk about toxic and metabolic, there's electrolyte abnormalities, hyperkalemia, acid-base disorders, cardiotoxic drugs like beta blocker, calcium channel blocker, and all of this can kind of cause it, okay? Infection causes, think about Lyme carditis is very common, bacterial endocarditis, acute rheumatic fever, endocrine thyroid, adrenal disease, neuromuscular, myotonic, and dystrophy. Pathophysiology, what happens in the AV block is an interruption of the electrical impulse. Anywhere within the AV conduction system, like it could be AV node, bundle of His, and left and right bundle branch block, okay? And the block at the AV node, impulses pass through the AV node, normal propagation through the conduction system, then it becomes the narrow QRS complex. And then infranodal block can be at the level or below bundle of His, and ventricular depolarization is impeded, then you can have the wide QRS complex. When you have more distal AV block, usually it results from extensive damage to the conduct system that like increased risk of progression. That's where like really, take it very seriously. You can have like complete heart block there. So what clinical features? It can remain asymptomatic. But if most of the presentation people have palpitation, syncope, dyspnea, dizziness, and then symptoms of heart failure, pulsation in the neck or chest, stochasm at times, like sudden loss of consciousness with the pre-prodromal symptoms, cardiac arrest, okay? And then when we talk about the EKG finding, this is the most important thing, progressive lengthening of the PR interval until a beat is dropped, okay? That means that a regular atrial impulse does not reach the ventricles. Okay, so normal P wave is not followed by the QRS complex. Most regular rhythm are separated by short pauses, which may lead to bradycardia, and rate of SA node is greater than the heart rate. So the Wenckembach pattern tends to repeat in P to QRS groups with a ratio of 3:2, could be 4:3 or 5:4. And then risk of progression to complete heart block, typically low. The block is because of at the level of the AV node. So remember, progressive lengthening of the PR interval, and that is until a beat is dropped. So you get a very clear picture over here. You look at the PR interval is prolonged, and then the beat is dropped. Okay, so treatment, first of all, you always do the reversible causes, and then correct electrolytes is very, very important. Maybe you keep your potassium above 4, magnesium above 2. Screen and treated acute coronary syndrome, again, the MI could be like one of the reasons. Symptomatic individual can give atropine temporarily before you put the pacemaker in. Patient with the persistent symptom, high risk of heart disease may benefit from placement of temporary pacemaker or cardiac pacemaker. So we got like a nice diagram over here. So if you diagnose, EKG show MOBITZ type 1 secondary heart block. If no symptoms, you can like, you can just kind of watch it. But if they're symptomatic and if they're unstable, start with the atropine and remain unstable. You go to transcutaneous, remain unstable, blood pressure dropping. You have to think about dopamine, and then, transvenous pacing. And then, of course, you have to put the permanent pacemaker in. If there is, first of all, you need to make sure all the reversible causes you have to ruled out. Okay, if there's no reversible causes, patient is unstable, and then you have to go for the permanent pacemaker. Remember that. So all the reversible causes we talk about, cardiac, all this need to be ruled out before you should consider like permanent pacemaker. Complication, heart failure, arrhythmia, heart attack, and sudden cardiac arrest should be the complications. So when you talk about some clinical polls, again, make sure you know the EKG finding, which is progressive lengthening of the PR interval until a beat is dropped. Okay, and then you have to think about at what situations we have to put the pacemaker in. Okay, and then you also have to know some of them can remain asymptomatic for a long time also. Thank you so much for watching. We'll be back with another presentation soon. Thank you.